Okay, so topic of discussion for today, we have upper GI bleed, acute upper GI bleed. What do you do? So, diagnostics, if you're suspecting an upper GI bleed, you will order the following tests: CBC, comprehensive metabolic panel, coagulation profile, and blood grouping and cross matching. So I remember this with the letter C. Most of these things starts with C. So C for CBC, C for coagulation profile, C for blood grouping and cross matching, C for comprehensive metabolic panel. Okay, get these done ASAP. Stat, sorry. And then you proceed to the acute management. So what's the acute management? Um, you'll obviously secure large bore IV cannulas on both arms. So usually 16 to 18 gauges. Some prefer 14 gauge. So basically the range is from 14 to 18 gauge IV cannulas. And you will you will give IV fluids. Normal saline 1 liter should be given as a bolus. And you should transfuse RBCs whenever they become available. Apart from that, give them supplemental oxygen, as oxygen is going to help with the oxygen delivery and all that stuff. And you will also check for check for any derangements of their coagulation panel. If the INR is greater than or equal to 1.5, you should give them FFPs. And if the platelet count is less than 50,000 in a case of active bleeding, then you should give platelets. Apart from that, endotracheal intubation. So this is done in cases when a patient is obtunded and they have massive hematemesis, or if the patient is having an active variceal bleed. Okay, and that's it for the acute management. So again, volume resuscitation, secure IV cannulas, transfuse 1 liter of give 1 liter of IV fluids, oxygen administration, correction of coagulopathy or platelet dysfunction, endotracheal intubation when indicated. And now we go on to the specific etiological management. So if it's an upper GI bleed that's not a variceal bleed, it's a non-variceal upper GI bleed, you will give them omeprazole. So IV, you give it IV. So usually the dose is 40 milligrams IV bolus given 12 hourly. That's IV. Or you could give 80 mg IV bolus followed by an infusion of 8 mg per hour IV. And this has shown tremendous help in preventing long-term sequelae of upper GI bleed and stuff. That's about it for the non-variceal upper GI bleed. So now come to the variceal upper GI bleed. So that means this patient is a cirrhotic or he has CLD. So in these patients, you can give them two things, whichever you like. One of them is octreotide. So that's somatostatin analog. So you give, the dosage for that is for 50 to 100 microgram IV bolus, followed by 25 to 50 microgram 50 to 25 to 50 microgram infusion. And you will continue this 3 to 5 days after the therapeutic endoscopy is done, because for the upper GI bleed the main therapy is endoscopy. So you will give the octreotide 3 to 5 days after endoscopy as well. You'll continue it. And the alternative to octreotide is terlipressin. So the dosage for this is terlipressin IV, terlipressin 1 to 2 milligrams IV, Q6 hourly. And also in a patient that's cirrhotic having a variceal bleed, they should be given antibiotic prophylaxis for 7 days, a 7-day course. So the antibiotics that you can give are ceftriaxone or cephalosporins, basically in IV form, commonly ceftriaxone, or the alternative is a fluoroquinolone. The usual dose for ceftriaxone is usually 1 to 2 grams IV. It's usually 1 to 2 grams IV Q24 hourly. And for fluoroquinolone, it's 500 mg IV Q12 hourly. That's usually what the dosages are. And so that's it. And if a patient is having like a upper GI bleed due to like a vascular malformation, it's like chronic refractory bleed, you can give thalidomide for that. But acutely, this has no usage. So the main therapy is therapeutic endoscopy. You basically can do So basically, for the bleeds, you can do like cauterization of the GI bleed, wherever it is in the stomach or in the esophagus. For varices, you can either do a ligation or banding. Banding is superior to ligation, and it actually has a protective or primary and secondary prophylactic effect equivalent to giving beta blockers. So for variceal bleeds, you will also give beta blocker prophylaxis to prevent the recurrence of these variceal bleeds. Okay. And apart from that, so sclerotherapy is also another method that's used, but I think banding and ligation are the most commonly used things. So for a gastric variceal bleed, actually, you can give cyanoacrylate, which is glue. So that's superior to banding and all that stuff, and it's more effective than beta blockers in primary and secondary prophylaxis for gastric variceal bleeds. All right. Other therapies for variceal bleeds are like TIPS and balloon occluded retrograde transvenous obliteration, but that's like not really important for us medics, us first line medic guys. So the main therapies that I just told you, please keep them remembered. What you're supposed to do: a guy comes in, IV fluids, oxygen, coagulation, correction of coagulopathy, be it from abnormal INR or from abnormal platelets. Intubate them if they need to be intubated. Transfuse them packed RBCs whenever you get the chance. If it's a non-variceal bleeding, omeprazole. If it's a variceal bleed, you give them octreotide or terlipressin. Okay, and also you give them antibiotics in the case of a variceal bleed. It's a 7-day course of antibiotic prophylaxis with either cephalosporin or fluoroquinolone, and therapeutic endoscopy is the treatment of choice. Usually controls all or majority of the bleedings of the upper GI tract, and that's about it.